Hi friends, welcome you all back to the nurse channel. So as you all know that two nursing officer exams are there in the queue. One is the PGI Sangrur and next is the Sri Chitra Tirunal nursing officer examination. So which is scheduled on January 8th. So like our old Jibmer series, so we are starting with the new series like the PGI Sangrur and SCT series, which help you to equip well for preparing for the upcoming examinations. So not only for the Sangrur and SCT, it will be helpful for other competitive exams like AIMS NORCET and ESIC, which are expecting very shortly. So without losing time, we will move on to the videos. Before that, I request everyone who are watching this video to kindly subscribe our channel and support us and share this platform to your nursing friends. So without losing time, we will move on to the new series, that is the SCT and PGI Sangrur series. 15 questions, very important questions. So stay tuned and watch till the end. Thank you. Hi friends, welcome you all back to the nurse channel. So as you all know that two nursing officer exams are there in the queue. One is the PGI Sangrur and next is the Sri Chitra Tirunal nursing officer examination. So which is scheduled on January 8th. So like our old Jibmer series, so we are starting with the new series like the PGI Sangrur and SCT series, which help you to equip well for preparing for the upcoming examinations. So not only for the Sangrur and SCT, it will be helpful for other competitive exams like AIMS NORCET and ESIC, which are expecting very shortly. So without losing time, we will move on to the videos. Before that, I request everyone who are watching this video to kindly subscribe our channel and support us and share this platform to your nursing friends. So without losing time, we will move on to the new series, that is the SCT and PGI Sangrur series. 15 questions, very important questions. So stay tuned and watch till the end. Thank you. So we'll start our session with the first question in this series. So the first question for you is in the screen right now. So the question is regarding the level of consciousness. So dash is a state in which the patient has a slowed response to stimulation and tends to sleep more than normal with drowsiness in between sleep states. Okay, so this is a definition of a particular level of consciousness. So here the patient has a slowed response to stimulation, tends to sleep more than usual and drowsiness in between sleep states. So what is this state called? That is a question for you. And the options are option number A, lethargy, option number B, stupor, option number C, obtundation, and option number D, clouding of consciousness. So which is this conscious state named as? So the answer for this question is option number C, that is obtundation. Okay, so obtundation, what is obtundation? Obtundation is a state which is similar to lethargy, in which the patient has a lessened interest in the environment, slowed responses to stimulation, and tends to sleep more than normal with drowsiness in between the sleep states. Okay, so drowsiness will be there in between the sleep states, and there will be slowed response to stimulation, and they have very lessened interest in the external environment. That is obtundation. Then we should understand what is lethargy. So lethargy, it consists of severe drowsiness in which the patient can be aroused by moderate stimuli. Okay, so here the term is moderate stimuli, and the patient then drift back to the sleep. Okay, so with the moderate stimuli, patient can be aroused, and the patient will be in the severe drowsiness stage. That is lethargy. Then what is clouding of consciousness? Clouding of consciousness is a very mild form of altered mental status in which the patient has inattention and reduced wakefulness. Okay, so that is clouding of consciousness. Okay, and the final option was stupor. So what do you mean by stupor? Stupor means that only vigorous and repeated stimuli will arouse the individual, and when left undisturbed, the patient will immediately lapse back to the unresponsive state. Okay, so stupor means only vigorous and repeated stimuli only will be arousing the individual, and if you are not disturbing the patient will immediately lapse back to the unresponsive state. Okay, so that is a stupor. So I think you are getting difference between stupor, lethargy, clouding of consciousness, and the answer for the question, that is obtundation. Okay, so we will move on to the next question in the series. Next question is a very important question. So the question is, the VIP scale provides a score from. So first of all, you should understand what is a VIP score, VIP scale in medicine. So The options for you are option number A 0 to 10, option number B 1 to 10, option number C 1 to 5, and option number D 0 to 5. So VIP scale provides a score within the range of dash. So that's a question for you. So we will be explaining about the VIP scale and how to interpret each score. That will be explaining in the explanation session. First of all, we will see the answer for this question. So the answer for this question is 0 to 5. Okay. So the Visual Infusion Phlebitis score, otherwise known as the VIP scale. Visual Infusion Phlebitis. So this scale provides a score from 0 to 5 in ascending order of severity of inflammation, and each grade identifies a more or less advanced state of phlebitis or thrombophlebitis and differs in the evidence of specific signs and actions to be taken. So in short, the score will give an information regarding when the IV line needs to be changed, what all actions to be taken for each score, that we will be seeing in very brief. So what is score 0? Score 0 means the insertion site appears normal and healthy and there are no signs of phlebitis. So the action is to continue observation of the cannula is indicated. Okay, that is score 0. Then score 1 means one of the following signs is evident. That means slight pain will be there or slight redness near the IV insertion site will be there. So these are the signs of early signs of phlebitis. Okay, so here also we can watch for the cannula. Okay, slight redness near the IV site or slight pain. Then comes the score 2. So score 2 means two of the following signs are evident, like pain will be there, redness or swelling will be there. Okay, so this is the early stage of phlebitis requiring repositioning of the peripheral venous catheter. So we have to remove the cannula and we have to reposition it. Then score 3 means all of the following signs are present. That means pain along the path of the cannula, redness around the insertion site, and swelling will be there. And this indicates the medium stage of phlebitis and the catheter need to be repositioned and treatment should be considered. So that is score 3. Then what is score 4? So all of the signs are evident and extensive. That means the pain along the path of the cannula, redness around the insertion site, swelling will be there, and one more thing, that is a palpable venous cord is evident. Then we can give a score of 4, and this is the advanced stage of phlebitis, and it is recommended to reposition the catheter and consider the treatment. Then final stage comes the score 5, and in this everything is evident. That means pain along the path of the cannula, redness around the insertion site, swelling, palpable venous cord, and pyrexia. Patient will, there will be temperature difference also. Pyrexia will be there. So this indicates the patient is in the advanced thrombophlebitis stage, and same, that cannula need to be replaced and another cannula to be inserted. Okay, so based upon this course we can identify what action to be taken for the present cannula. Okay, so for NABH accredited hospitals and all, this score is mandatory for all patients, and this chart also need to be maintained. Okay, so that was a very informative question for you. Now we will move on to the next question in the series, that is the third question, and the question is, what is the drug of choice for Graves' disease? So first of all, you should understand what is the Graves' disease. Then you can answer this question. So options are option number A, furosemide, option number B, digoxin, option number C, propranolol, option number D, propylthiouracil. So what is the drug of choice for Graves' disease? So obviously you know the answer. That answer is option number D, that is propylthiouracil. So you know that Graves' disease, otherwise known as the toxic diffuse goiter, it is an autoimmune disease that affects the thyroid, and it frequently results in, and it is the most common cause of hyperthyroidism. Okay, hyperthyroidism, Graves' disease. Okay, that you should remember. And we know that the main anti-thyroid drugs which are used in India are carbimazole, methimazole, and propylthiouracil. Okay, these are the three main anti-thyroid drugs: carbimazole, methimazole, and propylthiouracil. So these drugs blocks the binding of iodine and coupling of iodotyrosines. Okay, so this is the action of this anti-thyroid drugs. Okay, so keep in mind about these three drugs: carbimazole, methimazole, and propylthiouracil. Okay, so that's all regarding the third question. We will move on to the next question, fourth question in this series. So which IV fluids are given for DKA, that is diabetic ketoacidosis? So which IV fluids are given for DKA? And options are option number A, lactated ringer solution, option number B, 0.9% normal saline solution, option number C, 5% dextrose in water, and option number D, 0.45% normal saline solution, that is half NS. So which is the fluid, which fluid need to be administered for a patient in DKA, diabetic ketoacidosis. So easily you can omit some options very easily. So the answer for this question is option number B, that is 0.9% normal saline solution. So we have a protocol for the administration of fluids for the DKA patients. So safe practice of fluid resuscitation in DKA patients include provision of initial bolus of isotonic saline, that is our normal saline, at 15 to 20 ml per kg per hour. So this is the rate, 15 to 20 ml per kg per hour, which is followed by hypotonic saline solution, that is 0.45 saline. So first and foremost we have to give normal saline, then we have to come down to 0.45, that is a half saline, at a rate of 4 to 14 milliliter per kilogram per hour, as long as the patient's hemodynamically stable and corrected serum sodium is normal to high. Okay, so based upon these values we have to administer the fluids. Okay, so this is the rate. First is the isotonic at 15 to 20 ml per kg per hour, then comes the hypotonic with 4 to 14 milliliter per kg per hour. Okay, so this is the fluid management in DKA. Then normal saline is the most commonly used intravenous fluid in treating DKA, but it has a very high concentration of chloride and can lead to additional acid production when given in large volumes. So that's why we have set a value how much to be administered, and then we have to switch on to half saline. So normal saline itself cannot be given for a longer period of time with the if you are giving it in a overdose, it can result in another complications. Okay, so be careful while administering fluids for DKA patients. Okay, so I think that was a good information for you. Now we will move on to the fifth question in our series. So which anti-diabetic medication classification works by acting on the liver to decrease the overproduction of glucose by the liver? So here we are asking about an anti-diabetic medication which works by acting on the liver to decrease the overproduction of glucose, okay, by the liver. So the options are option number A, alpha glucosidase inhibitors, option number B, biguanides, option number C, meglitinides, and option number D, sulfonyl urease. So which drug will reduce the overproduction of glucose by the liver? So that is a question for you. Easy question. So the answer for this question is definitely option number B, that is biguanides. Okay, so we will have a small explanation regarding these anti-diabetic drugs. So biguanides means biguanides lower the blood glucose level by decreasing the amount of glucose the liver produces and releases into our bloodstream. So they also help lower blood glucose levels by making our muscle tissue more sensitive to insulin, so it can absorb glucose for energy. Okay, so it will make the muscle tissues more sensitive to insulin, so it can absorb the glucose for energy. Okay, so the example is the most commonly used metformin. Okay, biguanides, metformin. So we will see the other options also. So the next option was regarding the alpha glucosidase inhibitors. So as the name indicates, it inhibits the absorption of carbohydrates from the small intestine. Okay, so they competitively inhibit the enzymes that convert complex non-absorbable carbohydrates into simple absorbable carbohydrates. So it is inhibiting that process, and these enzymes include glucoamylase, sucrase, maltase, and isomaltase, etc. Okay, so the example for alpha glucosidase inhibitors are acarbose and miglitol. Okay, so these are the examples. So understood now that it inhibits the complex carbohydrate into inhibits the absorption of the carbohydrate. Okay, so the mechanism also already explained. Now we will see the another option, that is a meglitinides. Okay, so the next option was regarding the meglitinides. So meglitinides and sulfonyl urease will explain together. So sulfonyl urease and the meglitinides directly stimulate the release of insulin from pancreatic beta cells and thereby lower the blood glucose concentrations. Okay, so directly it is acting on the pancreatic beta cells, and then thus they are lowering the blood glucose concentration. So because they works by the stimulating the insulin secretion, they are useful only in patient with some beta cell that is functioning. Okay, so that is a very, very important thing. When we are prescribing this medicine, we should understand that this can be given only for patients whose beta cells are functioning. Okay, so the examples are repaglinide and natiglinide, and options for the examples for the sulfonyl urease includes that glipizide, glibenclamide and glimepiride. These are the second generation sulfonylureas which are in active use for the diabetic patients. Okay, so the action is almost the same. Okay, so it inhibits the it will stimulate the release of insulin from the pancreatic beta cells. Okay, so that is the action of meglitinides and sulfonylureas. Okay, so with that we have finished that question, and we will move on to the sixth question. So the question is, Gardner-wells tongs is a form of which traction? So question is, Gardner-wells tongs is a form of which traction? And the options are option number A, spinal traction, option number B, skin traction, option number C, bucks traction, and option number D, femoral traction. So Gardner-wells tongs. So Gardner-wells tongs is a form of spinal traction. So spinal traction is the answer. So we know that it was introduced in 1973 by Dr. James Gardner, and it have become a popular method of spinal traction, and there are several uses for this traction, including the treatment of cervical spine fractures, patient positioning inside the operating room, and skeletal traction during spinal deformity surgeries. Okay, so just remember this name, GWT, that is Gardner-wells tongs for spinal traction. Okay, so that Russell's traction, otherwise known as the form of traction which is used to align a fractured femur. Okay, that is the Russell's structure and traction, and the lower leg is supported in a sling just below the knee, and pulling forces are exerted upwards and longitudinally by means of pulleys and weights. Okay, so that is Russell's traction which is used for the fracture femur. And another was regarding the skin traction, otherwise known as the bucks traction. It is applied by strapping the patient's affected lower limb and attaching the weights. That is a form of skin traction. Okay, so I think you are getting some information regarding the types of tractions from that question. So moving on to the seventh question in our series. So question is, which neurotransmitter is responsible for many of the functions of the frontal lobe? So very careful, from the frontal lobe, which neurotransmitter is predominant? Okay, so the options for you are option number A, dopamine, option number B, GABA, option number C, histamine, and option number D, norepinephrine. So which one is more predominant in the frontal lobe? So the answer for this question is option number A, that is dopamine. So we will see the other neurotransmitters where they are predominant in the explanation session. So first of all, dopamine, it is a neurotransmitter that plays a key role in the reward and motivation, and is heavily active in the frontal lobe because most of the brain's dopamine sensitive neurons are located there. Okay, so dopamine, frontal lobe, that reward and motivation function. Okay, so remember that. Then regarding the another option, that is the GABA, that GABAergic neurons are located within the hippocampus, thalamus, basal ganglia, hypothalamus, and brainstem. Okay, so in these areas you can see the GABAergic neurons. Then the histaminergic neurons in the mammalian brain are located exclusively in the tuberomammillary nucleus of the posterior hypothalamus and send their axons all over the central nervous system. Okay, so in the posterior hypothalamus we can see the histaminergic neurons. Then comes the noradrenaline or norepinephrine. It is found in the cell bodies in the bones and medulla. Okay, so these are the predominant areas of some neurotransmitters what I have given in the option. Okay, so that also is a very informative and very important question. So we will move on to the next question in the series, that is the 8th question. So another important question, patient taking Acyclovir should be monitored for which among the following? Okay, so patient is on Acyclovir, so what you will monitor? That is the question. Options are option number A, cardiac profile, option number B, liver function test, option number C, renal function test, and option number D, complete blood count. So which is most important to monitor in a patient taking Acyclovir? That's the question. So the answer for this question is option number C, that is a renal function test, that is RFT need to be monitored for this patient. Why? Acyclovir, it is an important antiviral drug which is used in the therapy of herpes simplex and varicella zoster virus infections. And although the drug is well tolerated, severe nephrotoxicity, which often leads to acute renal failure, can happen in patients taking Acyclovir. So hence they have to be observed in the patients. Okay, so Acyclovir is can cause severe nephrotoxicity. So renal parameters, renal function tests like urea, creatinine, those things need to be monitored. Okay, so we will move on to the next question in the series, that is the 9th question. So the question is, what is the role of aspirin in the treatment of rheumatoid arthritis? So aspirin we are using in several settings, but in rheumatoid arthritis, what is the function of aspirin? So that is the question for you. So the options are: option 1, it reduces fever; option number B, it reduces the inflammation of the joints; option number C, it assists the client's range of motion activities without pain; and option number D, it prevents the extension of the disease process. So what is the function of aspirin in the treatment of rheumatoid arthritis? So that is a question for you. So the answer for this question is option number B, that it will reduce the inflammation of joints. Okay, so we know that aspirin and other NSAIDs are used to treat inflammatory symptoms in rheumatoid arthritis. Okay, they are used to treat the inflammatory symptoms. So aspirin exerts its effects on cyclooxygenase activity, which is linked to inflammation. Okay, so it is acting on the cyclooxygenase activity. So this agent exhibits analgesic, antipyretic and anticoagulation properties, also known as that acetyl salicylic acid. It is a commonly used drug for the treatment of pain and fever due to various causes, and it has both anti-inflammatory and antipyretic effects. Okay, so these are some another additional effects of aspirin in some other diseases. Okay, so our question was very specific. In rheumatoid arthritis, it is using for reduce the inflammation. So these are the other actions of aspirin, because it has both inflammatory and antipyretic effects. Okay, so we'll move on to the next question in the series. The 10th question for you is, which of the following laboratory values does the nurse expect to note in the client with gout? Okay, very simple question. So you should understand only a normal value of a particular thing, that's all. Okay, so the options for you are: option number A, uric acid level of 8 mg per deciliter; option number B, uric acid level of 2 mg per deciliter; option number C, phosphorus level of 2 mg per deciliter; phosphorus level of 8 mg per deciliter. So very easy question. So gout obviously related to what? Uric acid. So uric acid level of 8 mg per deciliter is the answer for the question. So just understand the normal uric acid levels. So it is 2.4 to 6 mg per deciliter in female patients and 3.4 to 7 mg per deciliter in male patients. Okay, so gout is caused by a condition known as hyperuricemia, where there is too much uric acid in the body. Okay, so the further points regarding the gout you can refer, like the drug of choice for the gout and other things. Okay, the dietary management. These are the other questions we can ask from the gout. So moving on to the 11th question in our series, and the question is, for a patient with hypomagnesemia, which of the following medications may become toxic? So patient is hypomagnesiemic, and if you are giving a particular medicine, means then it will become toxic. So which is that medicine? That is a question for you. So the options are: option number A, Lasix; option number B, digoxin; option number C, calcium gluconate; and option number D, CAPD. So which drug can cause become toxic for a patient with hypomagnesemia? So the answer for this question is option number B, that is a digoxin. Okay, so digoxin, it reduces the tubular magnesium reabsorption, and in patients with congestive heart failure, this interaction may be cumulative with other causes of magnesium deficiency. Okay, so digoxin, what will happen is it reduces the tubular magnesium reabsorption, and in patients with congestive heart failure, this interaction may be cumulative with other causes of magnesium deficiency. So magnesium deficiency can increase the risk of toxicity from digoxin. Okay, so that is very important. Okay, so that was a very informative question for you. Moving on to the 12th question in our series, and the question is, which among the following is one of the first signs of opioid withdrawal? So this is regarding the opioid withdrawal. So the question, you should be very careful. First sign, one of the first signs of opioid withdrawal. Options are: option number A, tremors; option number B, nausea and vomiting; option number C, diaphoresis; option number D, pinpoint pupils. So what is the answer? So the answer for this question is, the first sign of opioid withdrawal, that is diaphoresis, that is excessive sweating. So just we will have an why tremors usually will be the first sign for the alcohol withdrawal. Nausea and vomiting also same for the alcohol withdrawal. And pinpoint pupils, sometimes you may misunderstand this, because overuse of or overdose of opioids in the body can result in pinpoint pupils, okay, not with the withdrawal. Okay, so we will have a small explanation regarding this question. So onset of withdrawal depends on the half-life of the opioid that was used last. Okay, so the earliest withdrawal symptoms include agitation, anxiety, muscle pain, increased tearing, trouble sleeping, runny nose, sweating, yawning, goosebumps, dilated pupils, diarrhea, tachycardia, hypertension, abdominal cramps, etc. So these are the early withdrawal symptoms with opioids. Okay, agitation, anxiety, muscle pains, increased tearing, diaphoresis, trouble sleeping, runny nose, then goosebumps, dilated pupils, diarrhea, tachycardia and hypertension, etc. Abdominal cramps, etc. Okay, so don't confuse with the pinpoint pupils and dilated pupils. Pinpoint pupils, opioid overdose. Dilated pupils, early sign of opioid withdrawal. Okay, so we will move on to the 13th question in the series. So the question is, cystic fibrosis patients suffer pulmonary infections of all of the following pathogens except. Okay, so the patient is diagnosed to have cystic fibrosis, and you know that in cystic fibrosis already we have explained in our old videos. There will be mucus stacking will be there in the pathways, and there are high chances of getting infection. So which pathogen is not responsible for such infections? That's a question for you. And the options are: option number A, Pseudomonas aeruginosa; option number B, Haemophilus influenzae; option number C, Staphylococcus aureus; and option number D, Candida albicans. So what is the answer? So the answer for the question is option number D, that is Candida albicans. Okay, so we know that the cystic fibrosis lung disease is characterized by chronic inflammation and infection, and patients are predominantly infected by specific pathogens, of which the Staphylococcus aureus and Pseudomonas aeruginosa are the most important. Okay, and the other option what I have given, that is a Haemophilus influenza and Pseudomonas aeruginosa and Staphylococcus aureus, all these are important, but Candida albicans is not an answer. Not a pathogen that can cause the infection in cystic fibrosis. Okay, so we will move on to the second last question in the series. So what does egophony indicate? So what does egophony indicate? So the options are airway obstruction, option number B, airway consolidation, option number C, spasm, option number D, collapse. So what does egophony indicate? Egophony. So the answer for this question is option number B, that is consolidation. So what is egophony? So egophony, it is a severe form of bronchophony defined as a nasal or bleating quality of the transmitted vocal sound. Okay, so the quality of the sound will be changed. Okay, it is a severe form of bronchophony. So what is happening is, if the sound changes to A while the patient is saying E, so we have to ask the patient to say E, but we are hearing like that sound is hearing, means then egophony is present, that is positive. So this indicates the consolidation, or that there is a fluid in the lungs. So this egophony, this is another term to determine the presence of consolidation of the lungs. Okay, so that is egophony, severe bronchophony. Okay, so with that we will move on to the last question in the series. So it's a very important question. In adults, a normal CD4 cell count ranges from, okay, in adult. So what is the normal value of CD4 count? Option number A, 500 to 1200 cells per cubic millimeter. Option number B, 300 to 800 cells per cubic millimeter. Option number C, 1200 to 1800 cells per cubic millimeter. And final option, 100 to 300 cells per cubic millimeter. So what is the normal CD4 count in an adult? So the answer for this question is option number A, that is 500 to 1200 cells per cubic millimeter. Okay, so you know that the CD4 count is a very important parameter in diagnosing AIDS. So in adults, a normal CD4 cell count ranges from 500 to 1200. Okay, so a CD4 count of 200 or fewer cells per cubic millimeter may suggestive of AIDS. Not a confirmation, it is suggestive of AIDS. Okay, so that is a normal CD4 count. So with that informative question, we are coming to the end of this session. So the 15 questions what we have explained today are very, very important, and I request everyone who are watching this video to share this platform, about this platform, to your nursing friends and make use of it. And once again, thank you for watching the video till the end, and stay tuned. We will be coming with another set of questions very shortly. So till that time, signing out. Thank you.